Imagine you're the doctor on call, and the nurses in maternity ward or labor ward call you that Miss Jane Smith, a 28-year-old, now para 2, delivered a healthy baby vaginally after a prolonged labor. 10 minutes post-delivery, she experienced heavy vaginal bleeding with soft, boggy uterus. Despite initial oxytocin administration, the bleeding is persistent and her vitals show hypotension with a BP of 90/60 millimeters of mercury and a tachycardia with a heart rate of about 120 beats per minute with an estimated blood loss of 1000 mils. What is your most likely diagnosis and what are you going to do next? In this video, I'm going to teach you on postpartum hemorrhage. Remember, when you call for help, because every minute counts. Every minute counts. So by the end of this video lesson, you'll be able to confidently manage a patient with postpartum hemorrhage by being equipped with the knowledge and the skill to identify postpartum hemorrhage. You'll be able to possess the knowledge that enables you to identify and manage hypovolemic shock. You will also learn how to assess and manage the 4 causes of PPH, postpartum hemorrhage. And lastly, you will understand postpartum hemorrhage prevention and the WHO Postpartum Hemorrhage Management Protocol. Remember, get wisdom, get understanding. Let's dive in. So let's go back to the case scenario that we had. We have a female who is 28 years old and now para 2, just delivered a healthy baby vaginally after prolonged labor. So I'd like you to type in the comment section, what are some of the things that you're taking note of? One, this lady has prolonged labor and she's been bleeding for over 10 minutes. And in that 10 minutes, she has bled over 1000 mils. Okay, the uterus is boggy and it is soft, which is indicative of uterine atony. You've administered oxytocin, nothing is working. There's still persistent bleeding. Then you check the vitals, the BP is 90/60, and the patient is tachycardic. What's your most likely diagnosis and what do you do next? So, what are some of the important questions that you should be asking yourself if you find yourself in this situation? So, some of the most important questions, or the most important question that you can ask yourself in that moment is this postpartum hemorrhage? That's the first question that you should ask. Is this postpartum hemorrhage? Now, by definition, postpartum hemorrhage is when there is blood loss of greater than 500 mils in a patient who has delivered vaginally. Okay, so this is a vaginal birth, and the patient has an estimated blood loss of greater than 500 mils. And in a post-Caesar patient, the patient has bled for over 1000 mils during the C-section. Now the question is, how will you be able to estimate the blood loss? Okay, how will you be able to estimate the blood loss? So there are a few tools that have been formed to be able to estimate blood loss, both in SVD and in C-sections. So in SVD, one of the most usually what is done is just a visual estimation of blood loss. Now that is not very effective because it's subjective, it's based on expertise, and based on the research that was done, it turns out that there was an error rate of about 4%, okay, of more than 4%, and so there are some tools that have been established which can be more quantitative when it comes to the estimation of blood loss. So one of them is a calibrated blood collection drip. So that's what you see in the photo there. So what happens is that you put it at the buttocks of the patient, and whenever there is bleeding, it goes on the drip and into the collection bag. So you'll be able to see how much blood has been collected in the collection bag, which will give you a more quantitative blood loss. Another thing that you can do is we can use pads. Okay, every pad is estimated to be able to hold about 80 to 100 mils of blood. That is a normal sanitary pad. And so you can count how many pads have been used and how many of them were fully soaked to help you estimate the amount of blood that has been lost. Another way to estimate blood loss is by the use of kidney dishes. So the smallest is about 250 mils, the largest being able to hold about 1000 mils of blood. So it means you can position the kidney dish at the opening of the vagina, and whenever there's bleeding or you're massaging the uterus and there's bleeding going into the kidney dish, if it's full and it's a large kidney dish, then that's about 1000. The half of the largest kidney dish, that's about 500 mils. So you'll be able to quantitatively estimate the blood loss. Okay. Secondly, we said PPH in a post-seizure patient. This is when there's estimated blood loss of over 1,000, over 1,000. And how will you estimate the blood loss in this case? So in theater, we have abdominal swabs. So each abdominal swab is estimated to be 150 mils if it's fully soaked. So as the seizure is being done, if it's 1000, if there are two, then that's about 300. If there are four, that is 600 mils. Okay. If there are six, that is about 900 mils. Okay. So 8 fully soaked would give you around 1200, which crosses over the 1000, which is pointing us towards PPH. Another way is by, apart from the visual also, so it's in combination with, the blood which is on the gowns, the blood which is on the table, the blood which is, on the floor. So you can also look at the blood which is in the suction machine, okay, cylinder. So it has specific numbers, and so it will be able to tell you whether it's 100 mils, 500 mils, plus or minus the presence of liquor during the operation, or the presence of liquor in the cylinder. Okay, now PPH can be divided into two based on what time it occurs. So remember, we said PPH is if there's an estimated blood loss vaginally greater than 500, C-section, after C-section greater than 1000. So there is primary PPH and secondary PPH. So primary PPH happens within 24 hours of delivery, and then secondary PPH occurs from after 24 hours to up to 12 weeks postpartum. PPH can also be divided into, okay, it can be classified into three. There is minor, moderate, and severe PPH based on the amount of blood that has been lost. So minor blood loss is anywhere in between 500 mils to 1000 mils, then moderate from 1001 mils to 2000 mils, and then severe PPH is greater than 2000 mils. If it's PPH, then it's important to call for help because every minute counts. Every minute counts. So remember what we've just said. Remember what we've just said, that whenever you have to recognize that this is PPH. Okay, you're called the patient who's been bleeding. You have to estimate the blood loss, and if it's SVD and it's greater than 500, then it's PPH. If it's a post-seizure patient, it's greater than 1000, then it's PPH. Okay, and when you recognize that it's PPH, you need to call for help because every minute counts. Now that we have established that this is PPH, then what is the next important question that you should ask? So remember, the most concerning complication of PPH is hypovolemic shock. So you've established that your patient has been bleeding and you've established that it is in the PPH range. The next question is my patient in hypovolemic shock or not? You are standing before the patient, you've done your estimation of the blood loss, you've established that this is PPH. Your next question is my patient in hypovolemic shock? So hypovolemic shock, this is a significant blood or fluid loss which causes inadequate tissue perfusion and may lead to organ dysfunction, okay, the kidneys and different other organs. Okay, so that is hypovolemic shock. There's a significant blood or fluid loss. So the question is my patient in hypovolemic shock? So hypovolemic shock can be classified into 4 different classes based on different parameters, and these parameters are the blood loss based on percentage, okay, from the total blood in the body, blood loss based on the meals, okay, pulse rate, blood pressure, respiratory rate, mental status, skin signs, and urine output. So these are things that we're going to be looking at. So you have established this is PPH. You want to establish, is my patient in hypovolemic shock? So hypovolemic shock, as we mentioned, it's a significant blood loss, and this can be classified into 4 classes. So class 1 of hypovolemic shock is when a patient loses less than 15% of the total blood. This is less than 750 mils of blood. Okay, in this particular case, once you do the vitals, you find that the pulse rate is less than 100 beats per minute, the blood pressure is normal, the respiratory rate is normal, in between 14 to 20 breaths per minute, mental status is okay, the patient is alert, they're able to talk, they're functioning properly. When you look at the skin signs, the skin is normal, it's pink and warm, and the urine output is greater than 30 mils per kg per hour. Right? Class 2 of shock, okay? Class 2 of shock. This is when a patient loses anywhere in between 15 to 30% of the blood. Now remember our classification of PPH. We said we have minor, moderate, and severe. So you will notice that class 1 falls under minor PPH. Okay, and class 2 of shock is minor to moderate PPH. All right, so 15 to 30% of the total blood is lost. This is anywhere between 750 mils to 1,500 mils of blood loss. Okay, the estimated blood loss. The pulse rate is going to increase because the body is trying to compensate. So there's going to be a pulse rate of 100 to 120 beats per minute, which is tachycardic, like the patient that we are discussing. We'll go back to the scenario at the end. You will notice that the blood pressure will be normal or slightly low. The respiratory rate will be not very tachypnic, but it will be greater than the normal. So it will be anywhere between 20 to 30 breaths per minute, because remember, this patient is still trying to compensate. They're losing blood, so that means there's inadequate supply of oxygen and nutrients. So the body begins to compensate by causing the heart to beat faster and causing the lungs to take in more air, or increasing the amount of breaths so that you can increase the amount of oxygen. which is being supplied to the body. The patient becomes anxious, they are pale, and their skin is cool. The urine output is anywhere between 20 to 30 mils per kg per hour. Class 3 of shock, patient loses 30 to 40% of the total blood. So this is anywhere between 1,500 to 2,000 mils. So this is within the moderate range of PPH, the moderate PPH, classification of PPH. So the pulse rate increases. It's 120 to about 140 beats per minute. The blood pressure is low. Okay, it's below. Now the patient is hypotensive. So systolic is less than 90, diastolic is less than 60. Then we have respiratory rate, which is between 130 to 140 beats per minute. The patient is confused because of the reduced oxygen to the brain in different parts of the body. The patient has caught clammy skin because the body enters survival mode. So that means there's redirection of blood to important organs like the brain, the heart, the lungs, the kidneys, and different other important organs. There's shunting. And when shunting is occurring, remember, blood is responsible for the distribution of heat in the body. So what happens is that if there's reduction of blood in the peripherals, you find that the patient is going to have caught clammy skin. Okay, this is skin which is wet, okay, sweaty, wet, and very cold. And the urine output is going to be less, it will be 5 to 15 mils per kg per hour. Then we have class 4 of shock, which is very, very, very severe. So this is when a patient has lost greater than 40% of blood. So this is greater than 2,000, and this is severe PPH. The pulse rate is greater than 140 beats per minute. The blood pressure is critically low, so which is less than the normal values. It's maybe 60 over 30 or 75 over 45. It's low. The patient is lethargic and unconscious or unconscious. The patient also has cold, mottled, or cyanotic peripheries. So when you look at the skin, it's looking bluish and cold, okay, and wet. And the urine output is negligible. It's less than 5 mils per kg per hour. This is very severe, and it's not enough to identify shock. It's important to know what to do when you recognize shock at whatever class it may be. So I want us to look at how you can manage a patient now that you've recognized, okay, my patient is in shock. Whether it's class 1, class 2, class 3, class 4, my patient is in shock. What do you do? What's the next thing that you do? So we want to manage patients, and the parameters that we're going to use in management is monitoring, fluid resuscitation, oxygen therapy, the use of vasopressors, and the use of blood transfusion, okay, in our management of shock. And remember, anytime you have a patient who has PPH, remember your patient is losing blood. So you want to look for shock. Whenever there is PPH, you want to look for shock. And if there is shock, then you want to manage the shock in the way that we're going to discuss. Okay, and this is the general management. Then we'll look at the specifics where we find the cause and treat the cause. So if it is class 1 of shock, then you want to monitor the pulse rate, you want to monitor the BP, monitor the respiratory rate, you want to monitor the urine output. Okay, as we're doing the monitoring in class 1, in fluid resuscitation, it's based on the clinical presentation. Okay, you can manage the patient in a way that you want to prevent if there's active bleeding, the patient is still bleeding, we may want to give the patient oral fluids. If they're not able to, then we want to resolve to crystalloids like Ringer's lactate or normal saline. Okay, and this can run over an hour, it can run over 2 hours because the patient is stable. Okay, oxygen therapy in this particular case is not needed, vasopressors are not required, blood transfusion is not required. In class 2 or shock, the monitoring is the same. We still monitor the pulse rate or monitor the BP, respiratory rate, and urine output. So pulse rate, ideally want to be monitoring at the same time that we're monitoring the BP. So it's every 15 to 30 minutes, okay? Every 15 to 30 minutes, either quarter hourly or half hourly, and we want to be doing our respiratory rate at the same time, and we can check the urine output. So it means your patient should be catheterized, and you want to monitor how much fluids they're losing through the urine. Then, because the patient has lost anywhere in between 750 to 1000 mils, want to give 1 to 2 liters of isotonic crystalloids like Ringer's lactate or normal saline over 30 minutes to an hour, which should be an IV line. Then, if there is any respiratory compromise, then we want to put our patient on. Remember, in shock, the major challenge is that there's reduction of supply of oxygen and nutrients to important organs or to organs in the body, which will lead to organ dysfunction. So we may want to supplement oxygen by giving 2 to 4 liters per minute via nasal prongs. Vasopressors in this case are not required unless there's persistent hypotension. But remember, we said here the hypotension, the BP is going to be slightly low or normal, and because the body is compensating. And unless there is ongoing bleeding or severe anemia, there is no necessary requirement for a blood transfusion. In this case. In class 3 of hypotension, want continuous monitoring of vitals with a continuous monitoring of urine output. And what we want is a urine output of greater than 0.5 mils per kg per hour. Okay, should be greater than 0.5 mils per kg per hour. That's what we want to see. So we want a continuous monitoring. Okay, so it should be want to put our patient on some sort of monitoring device which will give us the BP, it's going to give us the pulse, it's going to give us the SpO2 as well. Okay, that's one other thing that you should monitor. So because the patient has lost blood, okay, anywhere in between 1500 to 2000 mils, so we want to give 2 to 3 liters of isotonic crystalloids or colloids. So the crystalloids are saying Ringer's lactate, normal saline. The colloids are talking about plasma, we're talking about albumin for over an hour. Okay, then we want to put our patient on high flow O2 via a mask or a non-rebreather. At least it should be 10 to 15 liters per minute. Okay, because they need a high flow of O2 because we want more supply of oxygen to the different parts of the body. If the hypotension is persistent after fluids, then we may consider giving norepinephrine, okay, vasopressor. Then again, in this case, because of how much blood is being lost, blood transfusion is very important. So we can order for urgent blood transfusion. At least within an hour, the blood should be there, and we should begin blood transfusion. Class 4, there is need for intensive monitoring of vitals and urine output. So ideally, we want to transfer our patient to ICU, intensive care unit, for constant and intensive monitoring. Okay, so because the patient has lost blood of greater than 2000 mils, we want to give 3 to 4 liters of isotonic crystalloids or colloids within 30 minutes. Okay, so this want a rapid flow, and want to put our patient on high flow O2 or mechanical ventilation. Remember, our patient is either lethargic or unconscious, so want to help them even with their breathing. Then want to give immediate vasopressors if the BP is low. Want to give norepinephrine or dopamine to help boost the BP. And lastly, want urgent transfusion with packed red cells. Okay, so it's important, and we may want to do a massive transfusion in this case. So now that you know how to identify hypovolemic shock, and you also know how to manage the different classes of hypovolemic shock, what's the next important question? Because imagine we treat the shock, but we don't treat the actual cause of the shock. Then it means we're not doing anything for our patient. So your next important question then is, where is the bleeding coming from? Where is the bleeding coming from? What is the cause of this PPH? Okay, what is the cause of this PPH? Pardon the APH there. What is the cause of this PPH? So PPH can be caused by ton. Okay, can be caused by ton. This is famously known as the 4 T's of PPH. The 4 T's of PPH. So the first T is ton, which accounts for about 80% of PPH. Accounts for 80% of PPH. So this is when there's abnormalities of the uterine contraction. So the uterus is not contracting properly. There are many different reasons that can lead to uterine atony. Some of them are overdistension of the uterus. For example, in a patient who has polyhydramnios, multiple pregnancy, macrosomic baby. So these are some of the things that you'll be looking for when you're taking a relevant history to find out, how, what happened to the patient before they began bleeding. What kind of baby did they give birth to? Okay. We're also thinking about intra-amniotic infections such as fever. A patient with prolonged rupture of membranes can be at risk of having chorioamnionitis, which will interfere with the contraction of the uterus. Also, we are looking at if there's distortion of the uterus in different cases, like for example, if there is rapid labor. Okay, if there's rapid labor, in precipitate labor, somebody took certain medication, okay, traditional syntocinon, and now they've caused very vigorous contractions that the uterus is tired. Okay, if there's prolonged labor, if there's the presence of fibroids, if there's the presence of placenta previa, or any uterine abnormality, it can lead to uterine atony. Then there's also the use of uterine relaxants such as magnesium, nifedipine, tubuline, halofen, which is used as an anesthetic. All these can function as uterine relaxants, and they can lead to uterine atony. And lastly, a distended bladder can prevent proper contraction of the uterus. So all these things can lead to uterine atony, and you have to look out for those risks. Okay, but uterine atony can cause PPH. Then we have tissue causes. Okay, we have tissue causes when there is a retained tissue. It can lead to improper contraction, which will cause bleeding. Okay, for example, if there is a retained product of conception, if there is a subcentriate lobe, so that means there's either a retained cotyledon, a lobe of the placenta, or there is a subcentriate lobe, which means this is a lobe which is isolated. Okay, it's not part of the entire placenta. It was located in a different place. It was isolated. Or there is retained blood clots. For example, if somebody had an abruption and there was a retroplacental clot, and so we've delivered the placenta but the clot has remained, it can cause bleeding to continue because there's going to be inadequate contraction at the site where the placenta or the retained tissue is. Then we have trauma. Okay, trauma can be due to genital tract injury. This is more common in instrumental deliveries, especially if we're going to use forceps. Okay, it can be injuries to the genital. If we have done an episiotomy, any lacerations to the cervix, to the perineum, especially if the patient begins to push before the cervix is fully dilated. If the patient has a previous history of a cesarean section and they undergo a spontaneous vaginal delivery, they risk having rupture. Also, in high parity, there is a risk of uterine inversion. Okay, uterine inversion, and all these things can lead to PPH. Lastly, we have thrombin. Okay, this entails coagulation. Okay, if there is an abnormality with coagulation, for example, if the patient has had a pre-existing coagulopathy like hemophilia A, the patient has idiopathic thrombocytopenic purpura bruising, if the patient has von Willebrand's disease, if the patient has a history of previous PPH, all these things can point us to coagulopathy. Or if this coagulopathy has been acquired during pregnancy, for example, if there is gestational thrombocytopenic bruising, if the patient has preeclampsia with thrombocytopenia, okay, e.g. in a case of HELP syndrome, okay, in the case of HELP syndrome, or if the patient has disseminated intravascular coagulation. Remember, pregnancy itself is a risk factor for DIC. Pregnancy itself is a risk factor for DIC. Other thrombin abnormalities, the patient may have had APH, which is postpartum hemorrhage, specifically a patient with an abruption placenta. Because of the bleeding, the patient can be in DIC. They may use up a lot of thrombocytes, which is going to lead to excessive bleeding afterwards. Okay, so we've discussed the different risk factors and the causes. Now, how do we assess and manage patients based on the cause of the bleeding? So we know how to identify PPH. You now know how to identify hypovolemic shock and how to manage it. And now we are looking at how do we identify and manage these different causes of PPH. So first, we're going to look at uterine atony. How do you assess uterine atony? So in our assessment, want to palpate the, of course, you do a brief history. We look for the risk factors that we've just discussed, and then you palpate the uterus. Okay, the uterus is going to feel bulgy, and it's going to be above the umbilicus after delivery. Okay, the height of fundus is above expected after delivery, because we know that after delivery the uterus should begin to contract, and it will ideally go below the umbilicus, below the level of the umbilicus. But if it's soft, if it's bulgy, and if it is not going down, then there is ineffective contraction. Okay, you can also do a bimanual examination, where you're examining through the vagina and also on the abdomen. You will feel the uterus being soft, dilated, bulgy, and not contracting effectively. And you may also want to look for the signs of shock, because the patient has been bleeding. So the signs that we already discussed about shock, you may also want to look for those. And If these check out, the uterus is bulgy, it's above the umbilicus, and by manual examination it is soft, it's dilated, it's bulgy, and there is bleeding, okay, which is not stopping, then our most likely diagnosis in that case is an atonic uterus. And so how do we manage a patient with an atonic uterus? There is need for adequate uterine massage. So you need to adequately and vigorously massage the uterus to encourage the uterus to contract. If the contraction is not happening with the uterine massage, then we want to go to our medical management. So you can give oxytocin IM 10 international units, or we can give 20 international units in 500 ml of normal saline, and we allow it to run as an infusion. Okay, if it is ineffective, we may want to use some stronger uterotonic medication like igometrin. Okay, if that still doesn't work, then we may want to do a bimanual compression. So you're compressing the uterus from the abdominal side and the vaginal side, and you're pushing, okay, to encourage the contraction. If that doesn't work, then we go into our surgical management by putting a uterine balloon tamponade. If it still doesn't work and the bleeding is uncontrolled and we want to save our patient, then we may do a hysterectomy, okay, in the case of uncontrolled bleeding as our last resort. All right, so what if the cause of the bleeding is retained tissue? How do we assess? So again, in our assessment, we want to look at the risk factors. Then we want to assess, okay, if there's persistent bleeding despite uterine contraction. If there's persistent bleeding despite uterine contraction, the uterus may still be bulgy, okay, despite our atonic interventions. We've given the oxytocin, we've given the other medication, we've done massage, but the uterus is still not contracting, or sometimes it will contract and relax again. It may be evidence that there's a retained placenta, there's a retained fragment or tissue. So once you do our clinical examination, okay, digital examination, you may find retained placental fragments, or when we do our assessment of the placenta, you may find missing lobes. Okay, you may find missing lobes. If we do an ultrasound scan, okay, you do an ultrasound scan, you may see retained placental fragments, okay, or this placenta accreta or pancreta, or there is a subcenturate lobe. We'll be able to pick up that on ultrasound scan. So if we diagnose that the cause of this PPH is retained tissue, how do we manage our patient? So how you manage your patient is, one, we do manual removal of the retained products. Okay, so manually with your hands, you go in and you declot and remove any retained products, any retained tissues. If that doesn't work, then we can also add medical management with oxytocin, either IM or IV, IV infusion. We can also employ the use of prostaglandins like carboprost or misoprostol, which is going to help with the contraction, and the contractions help to expel any retained tissues. If that doesn't work, then we want to do dilation and curettage. Okay, want to do dilation and curettage. If that doesn't work, then we want to do surgical exploration under anesthesia if the DNC doesn't work. So we take the patient to theater and we examine them under anesthesia to see what can be the cause of or where the retained products are. What if the cause is trauma? Okay, how do we assess our patient? There will be persistent heavy bleeding despite uterine contraction. So the uterus has contracted but there's still bleeding. You may find visible lacerations on the cervix or the vagina or the perineum on examination. If the abdomen is swollen and tender, it may point you towards a uterine rupture, especially if there's a history of having a past surgical intervention. We can also do an ultrasound scan, which will show us if there's a hematoma, internal bleeding, or a uterine rupture. So how do we manage our patient? You want to apply direct pressure on the source of bleeding and repair with sutures. So whether it's a first degree, second degree, third degree tear, or if there's a cervical laceration, then you want to apply direct pressure as you're preparing for suturing. So you repair with suturing. Medical management want to give a hemostatic agent such as tranexamic acid, want to give analgesics because the patient is in pain. If the internal injuries, then want to do surgical exploration with repair. So if in case we're thinking there's a uterine rupture, we take the patient to theater, we do exploration. If we find the rupture, we repair. And lastly, want to control infection by giving a broad spectrum antibiotic like amoxicillin. And we can also give metronidazole. Lastly, if the cause is thrombin, how do we assess? So the patient will have bleeding sites which are multiple, such as the gums, the IV line, the IV sites, surgical wounds is going to be bleeding. Patient is also going to have a spontaneous bruising and petechia. Patient will have oozing of blood despite contraction of the uterus. Then when we do our labs, our clotting profile, we may find that fibrinogen is low, it's less than 1 gram per liter. We'll find that the patient has low platelets, high D dimers because of fibrinolysis, and the patient will also have prolonged prothrombin time and active prothrombin time. Patient will also have a history of a coagulopathy or liver disease or signs of DIC when we examine our patient. How do we manage such a patient? We want to administer clotting factors or clotting factor replacement such as FFPs, okay, fresh frozen plasma. We want to give cryoprecipitates or platelets. So the FFPs want to replenish the clotting factors, okay. The cryoprecipitate want to replenish the fibrinogen, and the platelets want to replenish the platelets that have been lost. Okay, if there's any deficiency after we do our labs, then you want to do your medical management. Want to give tranexamic acid 1 gram IV stat. Want to inhibit fibrinolysis, which is occurring, and to promote clot formation. You also want to treat the underlying cause. If the patient has HELLP syndrome, then manage the HELLP syndrome. If the patient has DIC, then manage the DIC. Then want to constantly monitor the clotting profile. Okay. So, what is the WHO PPH Management Protocol? Okay, how do we put all these things that we've learned together? So the following is the flow chart, okay, with the different steps of the management of major PPH. Okay, remember that the minor is encapsulated in the major. So the mainstay is resuscitation, monitoring, investigation, and treatment. Okay, and this should occur simultaneously, and that is why it's important to have a team. So we're not doing this step by step, but these things should be happening at the same time because we are functioning as a team. So if there's major obstetric hemorrhage, okay, we're saying there's a blood loss of greater than 1,000 mils, okay, blood loss of greater than 1,000 mils, continuing major obstetric hemorrhage, or there is clinical shock, Okay, any of the stages that we've mentioned, the patient is in shock or there's major blood loss with estimation of greater than 1,000, then it's PPH. And if it's PPH, what do? You call for help. So you call for help, a senior midwife or an obstetrician, an anesthetist. You want to alert the hematologist. You want to alert the lab for blood transfusion. You want to alert the consultant obstetrician on call. Okay, so you call for help. You have people around. Then we begin resuscitation. In our resuscitation, we want to check the airway, breathing, and circulation. Okay, as part of our airway, we want to make sure that the airway is patent. Remember, our patient can be unconscious. Okay, the tongue can fall back. So you want to assess that the airway is patent. Okay, you call the patient. If they're able to respond, then the airway is patent. Okay, you want to assess breathing. Okay, that's where you also count the respiratory rate. You also want to ensure circulation. So we want to cannulate our patient, and we'll look at that when we discuss our monitoring and investigation. Okay, if the patient is in shock, according to what we discussed, put the patient on O2 at least in a mask. At least they should receive 15 liters per minute of O2. Want to balance the fluid, 2 liters of isotonic crystalloids, okay, or 1.5 liters of colloids. And as per protocol, when it comes to hypovolemic shock, what we have already discussed, want to do our blood transfusion if there is an indication, okay. Especially there should be availability of O negative blood, okay, which is a universal donor. We also want to make sure that the blood products are ready, okay, that is the FFPs, the platelets, the cryoprecipitates, and factor 7A. We want to keep the patient warm as well. As you do that, we now move on to our monitoring and investigation plus medical management. So under monitoring and investigation, you ideally want to cannulate our patient with 2 large bore cannula, want to collect bloods for full blood count, coagulation, urine, creatinine, LFTs, cross-matching. Ideally want to secure 4 units, okay, with FFPs, platelets, and cryoprecipitates. Okay, we can put our patient on ECG and oximeter so that we look at the SpO2. We want to make sure that our patient is catheterized because we want to be monitoring the urine output. HP bedside testing. Okay, want to ensure that the patient does not have severe anemia, because if they have severe anemia, then again want to do our blood transfusion. Make sure that the blood products are available. Consider central or an artery line, okay, and then want to commence the recording charts. So want to monitor the BP, monitor the pulse rate. We also want to collect any swabs that have been soaked and estimate the blood loss, okay, by weighing them, which is quantitative estimation of blood loss. At the same time, we would have begun our medical management. So wrap up the uterus fundus. Want to start with fundal massage. Okay. If there is urine, then we empty the bladder. So by catheterization, ensure that you give oxytocin 5 international units to run slowly, and we can repeat if necessary. So that can be in fluids. Okay. So ideally, you can give IV oxytocin, which is 5 international units IV, and we can give it slowly and repeat if necessary. If it doesn't work, then we can give igometrin 0.5 milligrams IV slowly or IM. Plus, we want to give oxytocin infusion, which is 40 international units and 500 ml of normal saline. We can also give prostaglandin like corboprost or carboprost, 0.25 milligrams IV every 15 minutes up to 8 times. And again, we're going to be checking the uterus and seeing if the uterus is contracting or not. Additionally, we can also give misoprostol 800 micrograms sublingual, and we may also consider giving tranexamic acid 1 gram IV. When do we take our patient to theater? We can take our patient to theater if the uterus is not contracting, for examination under anesthesia. Also, if there is any clotting abnormality that has to be corrected. Okay, so before we take to the theater, I want to find out, has any clotting abnormality been corrected or not, because we may worsen it with the surgical intervention that we will do. If the patient, if the uterus is still atonic and the patient is still bleeding, we may consider doing, or you may want to do, an intrauterine balloon tamponade, okay, or a breast suture. Consider an interventional radiology. That means we are doing our ultrasound scan to be able to guide us on where to intervene. Then surgery, we are doing a stepwise uterine devascularization. Okay, you can do a bilateral internal iliac ligation, and if it all fails, then hysterectomy. Afterwards, we'll send our patient to a high dependency unit or intensive care unit for monitoring. Now that we've discussed how to manage PPH, is there a way to prevent PPH? Yes, and the WHO has come up with a way that we can prevent PPH. Okay, how can we prevent PPH? By actively managing the third stage of labor. So active management of third stage of labor is in steps. So after a patient has delivered, step 1, we want to clamp and cut the cord. So we clamp the umbilical cord typically 1 to 3 minutes after birth. That's delayed cord clamping and cutting of the cord, and this prevents excessive bleeding from the placenta. So we clamp the cord, we've cut, the baby has already been delivered and being taken care of. Okay, so we don't want any more bleeding from the placenta, so we clamp the cord. Then second, we administer oxytocin after the palpation of the second twin. In case it was a twin pregnancy, you don't want to give oxytocin while the fetus is in utero. So you palpate for second twin, then we give 10 international units of oxytocin, okay, to promote uterine contraction, and we reduce risk of hemorrhage. After that, our third step is controlled contraction. So this is where you apply a gentle, steady traction on the umbilical cord with counter pressure. Okay, so you are gently creating traction downward on the cord. Okay, this helps the placenta to detach and prevent uterine prolapse. So we do the counter pressure to prevent uterine prolapse, because remember, one of the causes of PPH can be uterine invasion. Then we want to deliver the placenta. So as we are doing controlled contraction, we're waiting for the signs of placental detachment, which is elongation of the cord, appearance of the placenta on the opening of the vagina, and a gush of blood. So when you look for those, then you know that the placenta is detached. Then we can deliver the placenta. So we deliver the placenta within 5 to 30 minutes in a twisting motion, so that we ensure that all the placental tissues are expelled and we minimize retained placenta. Lastly, want to massage the uterus. So massage the uterus immediately after the delivery of the placenta and the membranes until it is firm. So you can continue massaging and examining the uterus every 15 minutes, for 2 hours after delivery. This promotes contraction and reduces the risk of hemorrhage. Ladies and gentlemen, now that you've learned this, I want us to go back to our scenario question, and I'd like you to type in the comment section what your answer is. We have Jen Smith, a 28-year-old, now para 2, who delivered a healthy baby vaginally after prolonged labor. So it's already giving you ideas of what kind of a problem it is. Okay, so 10 minutes post-delivery, she's experiencing heavy bleeding with a soft boggy uterus indicating uterine atony. Despite the initial oxytocin administration, the bleeding is persistent and her vitals show hypotension and tachycardia with an EBL of 1000 mils. What is your most likely diagnosis and what are you going to do next? So type your management based on what you've learned. And I did a video on APH for those who have not seen it. If the bleeding occurs before delivery, after the age of viability before delivery, I'm going to target. So just click on the pop-up so that you may watch that video. And also I did another video for you on prom, okay, on prom. So you can also follow, and I'd like you to subscribe for more content like this. I want you to also type in the chat what other topics that you would like me to tackle in the near future. Thank you. All the best. Go and save lives.